series, our research series. Dr. Doolittle, I think we are preparing to get started.
Great, great. Good afternoon, everyone, and welcome to our first program of, forgive me, just lost, there we go. Welcome to the Kansas and Missouri Cancer Research Highlight Series. This is hosted by the Masonic Cancer Alliance and the University of Kansas Cancer Center. On behalf of the MCA and the KU Cancer Center staff, we really appreciate you taking time out today to be here with us. I'm Dr. Gary Doolittle. I'm the medical director of the MCA. I'm a medical oncologist at KU Cancer Center, and I'll be moderating today's session. Before we get started, we have a few housekeeping items. First, as a reminder, the Zoom session is being recorded. Second, all participants will remain muted throughout the program. If you'd like to ask a question, please type your question into the chat box. And we have dedicated times during the program where MCA staff members will be posing your questions to our presenters. Finally, please remember when you ask questions to leave out any patient information. All right, let's get started. Our first speaker is Dr. Qamar Khan. He is the director of the Breast Oncology Program at the University of Kansas Cancer Center. His research interests include neoadjuvant endocrine treatment and therapy escalation in early breast cancer and therapy de-escalation in metastatic breast cancer. Dr. Khan, welcome.
Thank you to Dr. Doolittle and the MCA for this opportunity. On behalf of my co-investigators, I will now present the FELINE trial. I presented this trial as an oral presentation at the ASCO virtual meeting of 2020.
So Mom, do we put something over this? Well,
Okay.
Please continue, Dr. Khan.
Okay, so here is the basic research question that the FELINE trial has asked. And the question is, can ribociclib given before surgery decrease the need for chemotherapy after surgery in estrogen receptor positive breast cancer? Ribociclib plus endocrine therapy is superior to endocrine therapy alone in metastatic breast cancer. The FDA approved dose is 600 milligrams, 3 weeks on, 1 week off. Safety and efficacy of a lower dose given in a continuous fashion has not been studied. Neoadjuvant endocrine therapy in estrogen receptor positive breast cancer provides an opportunity to study on treatment endocrine sensitivity in a more dynamic fashion. This information may inform decisions regarding adjuvant chemotherapy. It facilitates collections of serial biopsies and increases rates of breast conservation similar to neoadjuvant chemotherapy. Pathologic complete response and residual cancer burden are excellent surrogates for long-term outcomes from neoadjuvant chemotherapy, but not endocrine therapy. Clinical and radiologic responses are not very predictive of long-term outcomes in ER-positive breast cancer. Short-term Ki-67 after starting neoadjuvant endocrine therapy predicts relapse, and a value of more than 10% is an early indicator of recurrence from breast cancer. Preoperative endocrine prognostic index score, or PEPI score, is an algorithm that combines anatomy and biology. It uses tumor size and nodal status as well as Ki-67 and Allred ER score while the patient is on uninterrupted endocrine therapy. It was tested in P24 neoadjuvant trial and later validated in the IMPACT trial. PAPI score of 0, which consists of tumor size up to 5 centimeter, node negative status at surgery, Ki-67 of 2.7% or less, and an ER all-red score of 3 to 8 is associated with a very low risk of recurrence without the need for adjuvant chemotherapy. FELINE is a multi-center randomized placebo-controlled trial. Postmenopausal females with stage 2 or stage 3 ER positive, HER2 negative breast cancer having a breast primary of at least 2 centimeter were randomized equally to Group A, which was placebo plus letrozole, Group B, which was ribociclib 600 milligrams daily, 3 weeks on, 1 week off, plus letrozole, or Group C, ribociclib 400 milligrams continuous daily, plus letrozole. Protocol treatment of 6 28-day cycles was continued until the day before breast surgery. Core biopsies and blood were obtained at baseline, day 14 after cycle 1, and at the time of surgery. Patients who had a Ki-67 of more than 10% at day 14 of cycle 1 were taken off the trial. Treatment after surgery was at the discretion of treating physician. An easy way to remember the group assignments in future slides is that Group C stands for continuous dosing group. Here are the participating collaborating sites. As you can see, it spans all over United States, and it's an example of a very collaborative effort on the part of an IIT. The primary objective was to find out if addition of ribociclib to endocrine therapy increased number of women achieving a PAPI score of 0 and therefore excellent prognosis without adjuvant chemotherapy. For the primary analysis, groups B and C, the two ribociclib containing groups, were combined versus group A, which was letrozole alone. Primary endpoint was proportion of the patients achieving a PAPI score of 0. Secondary endpoints were day 14 complete cell cycle arrest, defined as Ki-67 of 2.7% or less, and clinical ultrasound and MRI response rates. Other endpoints included efficacy and toxicity comparisons between the two ribociclib groups B and C. Baseline characteristics are shown here. They were no different between the groups. Group A had numerically more invasive ductal carcinomas and more T3 and T4 tumors. There were 10% more node positive patients in Group A compared to Group B plus C, but this was not statistically significant, although there were numerical differences. Here is the primary endpoint. There was no difference in PAPI score of 0 between placebo and ribociclib. 25.8% of the patients in Group A had a PAPI score of 0 compared to 25.4 in Group B plus C. Shown also are the individual components of PAPI score comparing A versus B plus C. There was no difference in patients with T1, T2 tumors. Numerically, 10% more women had node negative disease at surgery in Group B plus C. However, please recall that this difference was seen at the baseline as well. There was no difference in Ki-67 values of 2.7% or less at surgery and no difference in all-red ER score. Individual data from group B and C is shown in the two right columns. Clinical, ultrasound, and MRI responses are shown here. There was no difference in clinical response, ultrasound response, or MRI response. The graph on the right is showing response rates of patients in group B and C individually, and there is no difference between the two groups as well. Shown here is the Ki-67 data between baseline and day 14 of cycle 1, meaning it just 14 days after the treatment is started. The graph shows data on each patient on the right side. The median baseline Ki-67 was 15.8% in group A and 21.4% in group B plus C. 17% of the patients in group A and 4% of the patients in group B plus C had a Ki-67 of more than 10% at day 14, cycle 1. Between baseline and day 14, cycle 1, average change in Ki-67 was minus 15.7% in group A and minus 23.3% in group B plus C. 92% of the patients had complete cell cycle arrest in group B plus C compared to only 52% in group A. This difference had a p-value of less than 0.0001. Ki-67 change from day 14 cycle 1 to surgery is shown in this table. The graph shows data of each patient from baseline to day 14 cycle 1 to surgery, so 3 time points. Between day 14 cycle 1 to surgery, 66% of women in group B plus C had an increase in Ki-67 compared to 33% in group A. This difference had a p-value of 0.006. And because of this increase in the group B plus C, complete cell cycle arrest at surgery was not different in group A versus group B plus C. Here are the AEs of interest. Not surprisingly, there were no grade 3 or 4 toxicities in group A. The rates of grade 3 or higher AST, ALT elevation was similar in group B and C. Grade 3 or 4 neutropenia was 32% in group B and only 7% in group C. QTC prolongation, mainly low grade, was seen in 24% of the patients in the continuous ribociclib group and 0 in the intermittent ribociclib group. In conclusion, in stage 2 or 3 ER positive early breast cancer, addition of ribociclib to letrozole as neoadjuvant therapy did not increase the number of women with a PAPI score of 0. In this neoadjuvant trial, ribociclib plus letrozole had similar clinical, ultrasound, and MRI responses compared to letrozole alone. Addition of ribociclib to letrozole led to near doubling in proportion of women achieving a complete cell cycle arrest at day 14 of cycle 1, 92% versus 52% respectively. This early Ki-67 suppression at day 14 cycle 1 was not maintained at surgery. This may indicate early on treatment acquired resistance to ribociclib in some patients. Correlative studies are ongoing to answer this question. In the neoadjuvant setting, ribociclib 400 milligrams continuous dose has similar efficacy, similar rates of elevated liver enzymes, less neutropenia, and more QTC prolongation compared to the 600 milligrams intermittent dose. So the highlight of my presentation was right after the presentation, I got this tweet, Dr. George Sledge who tweeted this, and he said, Feline trial was his favorite trial name of the meeting. And he went on 3 or 4 tweets explaining the trial. Thank you very much for your attention.
Thanks, Dr. Khan. Ashley, do we have any questions for Dr. Khan?
Right now, we just have one. Dr. Khan, can you share a bit about how your research has impacted clinical practice?
So right now, we actually we were not able to show that giving ribociclib added to letrozole improves PEPI score of 0, so avoiding the need for chemotherapy. So the trial was negative in answering the clinical questions. However, I think the more important part of this trial is we have tissue collected at baseline and at day 14, cycle 1, and at the time of surgery as well. And we are doing all kinds of DNA and RNA work to answer question of why these patients are resistant to ribociclib and improve upon the scientific knowledge of this resistance to CDK4/6 inhibitors. So right now, it did not change the clinical practice.
Great, thank you. We have one more question right now. We have a participant who's interested in knowing if certain ethnicities or races experienced greater adverse events on the study.
So the majority of our population was Caucasians. There is about 8 to 10% women were non-Caucasian minorities, and our trial is not actually big enough to answer that particular question.
Okay, thank you, Dr. Khan. That's all the questions we have for him right now, Dr. Doolittle.
Thank you.
Thank you. Our next presenter is Dr. Anwaar Saeed. Dr. Saeed is Assistant Professor of Medical Oncology at the University of Kansas Cancer Center. She's an active member of the GI Oncology program and the early phase program at the KU Cancer Center. Her clinical research is focused on developmental therapeutics and, sorry, we lost our. Her clinical research is focused on developmental therapeutics and immune modulatory approaches in patients with advanced gastric, esophageal, colon. She also has an interest in chemo prevention in the high-risk GI population. She's leading the clinical research initiatives of novel therapeutics in these areas. Dr. Saeed trained here as a fellow. She had a brief stint at the University of Wisconsin-Madison, and then joined the faculty back again at KU in late 2016. She's been successful in securing multiple external research grants to support several novel investigator-initiated trials. Dr. Saeed.
Thank you, Dr. Doolittle. Do you hear me?
Yes.
Yeah, thank you for the invitation. It's my pleasure to be here and present some of our work that's been ongoing and some of it that's completed as well. So we will start with so I will highlight the CAMILLA trial, which is an investigator-initiated trial that that I developed during my time here at KU Cancer Center. It's a phase 1/2 trial looking at the combination of cabozantinib with durvalumab in patients with advanced gastroesophageal cancer and other gastrointestinal malignancies. Next slide. I'm trying. Somehow I don't have the slide set in front of me.
Tracy, can you help us with this set of slides for Dr. Saeed, please?
Yes, just one moment.
All right. So just to give a background on the rationale behind combining a VEGF-targeted therapy with immunotherapy, pembrolizumab, which is a PD-1 inhibitor, was approved in third-line setting for patients with gastric and gastroesophageal junction adenocarcinoma based on the KEYNOTE-059 trial. So in this trial, which is a phase 2 multi-cohort study, pembrolizumab in cohort 1 was explored in the third-line setting in this patient population. And the results of that cohort revealed that in an unselected population, the result was not significant. With the overall response rate was around 5% in an unselected setting. However, when they've done a subgroup analysis to look at whether the result is better or not in differential population, looking just at the PD-L1 positive disease, the overall response rate was 15% in the PD-L1 positive, as opposed to 6% in the PD-L1 negative patients. The median progression-free survival in that trial was around 2 months, and the median overall survival was 5.6 months. So based on the differential impact or the favorable impact in the PD-L1 as opposed to PD-L1 negative in the third-line setting, and because or considering the unmet need of agents in the third-line space, despite that the result is not that clinically meaningful, the FDA ended up approving this drug as single agent for the PD-L1 positive population in the third-line setting. Next slide. So coming to cabozantinib, so why are we looking at combining cabozantinib with the PD-L1 or PD-1 inhibitor? We know that the results with monotherapy, whether we're going to use pembro or other agents, chemo or biologic agents, the results are not meaningful. And so there's a great room for improvement by capitalizing on what we have as standard of care. And in this proposal, I've proposed cabozantinib as a candidate drug. This is a VEGF, a co-VEGF MET tyrosine, multi-tyrosine kinase inhibitor that, in addition to blocking VEGF and MET, blocks multiple other tyrosine kinases. And the good thing about this multi-tyrosine kinase inhibitor, as opposed to other VEGF tyrosine kinases, is that it is one of the unique VEGF tyrosine kinase inhibitors in the market, being one of the few drugs that target MET. And MET in GI malignancies has likely to have a potential because of the preclinical data supporting MET amplification as a resistant mechanism post-VEGF targeted therapy. And as we know, in GI malignancies, upper GI as well as colon and HCC, we frequently use VEGF targeted therapy in multiple lines of therapy. And so using cabozantinib in a chemorefractory setting makes sense here. So in a phase 2 trial looking at this drug in multiple disease cohorts, including a cohort of patients with gastric and gastroesophageal junction cancer, cabozantinib showed some efficacy as single agent in this disease, with an overall response rate of around 10% and disease control rate of around 30%. Next slide. So the preclinical rationale, why combining a VEGF tyrosine kinase inhibitor with IO, and why cabozantinib? So this drug has shown, in addition to its cytotoxic effect due to blocking of those pathways, it has shown immunomodulatory effects in animal models. And it has shown impact in terms of synergizing with immune checkpoint blockade. So in a colon cancer model, the results of investigating cabozantinib in a colon cancer model by Quilas et al., published in Translational Journal of Translational Medicine in 2014, showed that cabozantinib was able to modulate the immune system by boosting the T effector cells, CD8 and CD4 cells, and suppressing the immune suppressor cells, MDSCs and Tregs. And in another model, in a prostate cancer model, that model showed intriguing data that this drug synergizes with immune checkpoint inhibitor. This was published in Nature back in 2017, and as you see, it has shown a significant synergy when cabozantinib was combined with immune checkpoint inhibitor by significantly suppressing MDSCs when compared to either drug alone, and significantly boosting the CD8 Treg ratio when compared with those two drugs alone. Next slide. Another evidence supporting combining VEGF tyrosine kinase inhibitors with PD-1 inhibitors in this population, gastric and gastroesophageal junction adenocarcinoma. This is not a US data. This is the regorafenib alone data was European data, and as you see here, using regorafenib monotherapy, this is another VEGF tyrosine kinase inhibitor in this disease in a third-line setting. The overall response rate based on this phase 3 study was 3%, and a median progression-free survival was 2.6 months, with a median overall survival of 5.8 months. So as you've seen here, the results of this is comparing similarly to the results we've seen with pembrolizumab monotherapy in a third-line setting, which brings the question of whether those results are related to just the disease course versus the drug. So, I mean, very poor response to monotherapy in the third-line setting. However, the impact of adding a checkpoint inhibitor to a VEGF tyrosine kinase inhibitor clearly showing synergy here. So recent data, Japanese data presented at ASCO when combining regorafenib with nivolumab in the microsatellite stable gastric cancer population, as you see more than doubling of the overall response rate, 44%, and more than doubling of the median progression-free survival, 5.8 months. This is, again, a small study that looked at a cohort of gastric cancer and also another cohort of colorectal cancer population, but very early promising data supporting the synergistic impact of this combination. Next slide. So coming into our trial, this is the phase 1 results that I've presented at this ASCO 2020 meeting. It's a phase 1b trial combining cabozantinib and durvalumab in patients with advanced gastroesophageal cancer and other GI malignancies. So the phase 1 is a 3+3 design followed by dose expansion. So for the 3+3 design, patients received escalating doses of cabozantinib from 20 milligram to 40 milligram to 60 milligram combined with a flat dose of durvalumab 1500 every 4 weeks. And so pretty much easy logistics as opposed to chemo regimens. And this was, we've completed phase 1, the dose escalation, and we moved to the dose expansion. In this dose expansion, we've arrived into the recommended phase 2 dose being 40 milligram of cabo combined with durvalumab 1500 every 4 weeks. So we looked at recommended phase 2 dose, which is 40 milligram for cabo, and we looked at secondary endpoints, including safety, overall response rate, disease control rate, and survival outcomes. We've also sampled tumor tissue at baseline prior to study enrollment, and for some patients who had disease response, they had their tumor sampled at time of response as well, which will help us know some of the mechanisms of how those two drug combinations work and mechanism of resistance. Next slide, please. So this is just showing the baseline characteristics of the study population. I will not go through the details, but just to highlight that the study is a GI basket study, and it's becoming patients with chemo-refractory disease who are either advanced gastric esophageal adenocarcinoma, colorectal cancer, and hepatocellular carcinoma. For the gastric and esophageal cohort, we're looking at patients failing frontline therapy, regardless of PD-L1 status. And if they have HER2-positive disease, they have to fail Herceptin to be enrolled on the study. The colorectal cohort is looking at patients failing 2 lines of chemotherapy and failing an EGFR-targeted agent if they have RAS wild-type phenotype. And for the hepatocellular carcinoma patients, and given the data recently supporting the use of immunotherapy in the frontline setting, the trial was amended to allow the HCC population in the frontline setting. So whether they are treatment naive or pre-treated, they are welcomed in the study. And including the study is also open for the population of patients who fail immunotherapy. And that's supported by the rationale that cabozantinib could reverse resistance to immunotherapy treatment. Next slide. Next slide. So this is the safety results of the study. It compares favorably with studies that looked at VEGF tyrosine kinase inhibitors and IO combinations and other disease types. Overall, we've seen around 30% grade 3 and above toxicities. And we did not see any unexpected safety signal. Next slide. So this table is showing the most common treatment-related adverse events that we've seen on the study. Most of the patients developed a degree of fatigue, but mostly grade 1 and 2. Anorexia in around 40% of the patients, diarrhea, transaminitis, elevated TSH or hypothyroidism, hypertension, hand-foot syndrome in around 14% of the study population, and immune-related pancreatitis in some patients. So this is overall similar to what expected and similar to what we would expect with a combination of VEGF targeted therapy and immunotherapy. Next slide. So this table summarizes the tumor response. So overall, looking at, we have 20 patients who had evaluable disease at the end of the study. Overall response rate was 25%, which is impressive. And that means in 20 patients, 1 in every 4 patients who went on the study developed or had significant tumor shrinkage. And most of the patients had stable disease. So the disease control rate was 85%. So of the 20 patients who were evaluated, 17 did not progress or had stable disease, which is very impressive in a chemorefractory population and very impressive to see in a GI malignancy basket study, because historically in a GI malignancy space, we don't typically see responses or this degree of stable disease in the chemorefractory population setting. Next slide. So this is just highlighting what we've seen. There is a waterfall plot on the left-hand side showing, the red bars and the gray bars signifying that we've seen responses in both the colorectal population and the gastric population. We did not have a lot of HCC patients in the study, so the results of those populations is not highlighted here. But as you see, we've seen responses in colon and gastric. If you look at the spider plot, it's showing that we've had patients who crosses the 1-year margin and still doing fine on the study, which is extremely impressive. And I've as a GI oncologist, this is to me extremely impressive and very good, promising early signal. If you look at the swimmer plot on the right-hand side, you've seen that we still have patients who are maintaining their response and while on the study. Next slide. So future directions, or where are we going from? Where are we taking this? Next slide. So the study, based on the phase 1 results, AstraZeneca and Exelixis graciously supported the research mission and supported the expansion of this study from phase 1 study to a phase 1/2. So we've recently opened the phase 2 portion of the study, which is a multi-cohort trial with 3 phase 2 trials running in parallel, looking at this combination in gastric esophageal patients, colon cancer population, as well as the hepatocellular cancer patients. And so we're looking at around 30 patients in each cohort, which increases the study size to around 96 patients. we're looking at multi-center to ensure that we complete the enrollment and get and then present the results in a short timeline. And so the study is currently open at KU Cancer Center, but we're looking at opening it soon at Memorial Sloan Kettering Cancer Center, as well as 4 other U.S. sites. Next slide. Based on the available data supporting the rationale of combining VEGF tyrosine kinase inhibitor with PD-1 inhibitor in this disease particularly, and based on the fact that the standard of care in the third-line setting for the PD-L1 positive population is pembrolizumab, and the fact that there is more and more data supporting the use of Cabo in combination with IO in multiple disease types, including renal cell carcinoma, prostate cancer. There's recent data presented supporting the use of Cabo with IO in prostate cancer, very intriguing data, as well as the data supporting using it with IO in hepatocellular carcinoma. And so based on all of this, I've proposed a trial to a cooperative group through SWOG, and the trial is looking at comparing cabozantinib with Pembro versus Pembro in the third-line setting for the PD-L1 positive population. So this is a pivotal study that will open soon. A SWOG intergroup study S2009. And we're hoping that this might move the field and possibly register cabozantinib as one of the latest additions to the treatment armamentarium of this deadly disease. Next slide. And I just want to highlight another thing that for this particular population, which is my research, which is my focus and research interest, I have another investigator-initiated trial that is ongoing right now, looking at a PARP inhibitor or Rucaparib in combination with ramucirumab, with or without nivolumab in this patient population. And just for the sake of time, I'll just briefly highlight the rationale behind this combination, that there is some data supporting some synergy when combining PARP inhibitor with VEGF-targeted therapy. Preclinical models have shown that inducing hypoxia with VEGF-targeted therapy downregulate homologous recombination repair genes, or HRD genes, and upregulate PD-L1. And this creates a phenomenon in pathology called synthetic lethality, which is when we simultaneously inactivate pathways that the tumors depend on for survival. This leads to cellular death. So this was seen in preclinical models and supports the idea behind combining Rucaparib with VEGF. And because immunotherapy has shown some synergy with VEGF-targeted therapy, it makes a very strong sense of adding nivolumab to Rucaparib and RAM in this patient population, specifically because ramucirumab is also a standard of care in the second-line setting for this group. And so this study and this design will help us address a number of questions. One of it, first one is whether there is synergy clinically, as was seen in clinical models, and then two, if adding nivolumab will boost the efficacy of the two drugs, Rucaparib and RAM. And also the third question, to address the third question of whether this could be tailored to the HRD positive population versus the unselected all-comer population. So 50% of enrollment to this trial will be tailored to patients who have one of those genes listed in the table below. So this study is right now open at KU Cancer Center and the KU community sites, as well as MCAs, and soon will be open at the University of Chicago as well. So we welcome your support for enrolling patients on this high-impact trial. Thank you. Next slide.
Great. Dr. Saeed, thank you very much. Are there any questions for Dr. Saeed?
Hello, Dr. Saeed. Thank you for a great presentation. We have several community members and patient advocates on the call today, And the question that I've received is, how long will it take to go from a phase 1 study that you described with your first study description into practice-changing processes? So when does it get into the clinic?
Yes, so it really depends on what are we talking about when we talk about phase 1 studies and what the type of the drug, because it is a lengthy process if we're looking at first-in-human studies. So if we are exploring a drug in phase 1 in a first-in-human study, taking that drug, showing that drug is safe, and then showing some efficacy, and then moving beyond that to improve that it is impacting survival takes a long time. But if you look at the length of time from inventing drug to approving drug across time in oncology, if you go back to the 60s and 70s, it takes more than a decade, much more higher than a decade to approve a drug. But nowadays, I would say over the last decade, we've started seeing much faster timeline from seeing an efficacy in a phase 1 and moving it to a phase 3 FDA registration trial. And the reason for that is the improvement in our phase 1 design. So thanks to all of the biostat effort that's working on improving our designs for phase 1. So in the old time, we typically use 3+3 design for most of our studies. Now we have tons of designs that could shorten that period of examining a drug in a phase 1 setting, and that helps a lot in that timeline. And the other thing is, if we are exploring a drug that's already explored in other disease types, that also hastens the timeline process, because the safety is already known. We're just proving it safe in a different population. And also selling that drug, like when talking to patients about a drug that's already showed efficacy in another disease, selling the trial is not hard if you are exploring it in a different disease.
Thank you. And I think that's the basket study approach that you were talking about as well. We have another question for you. Patients who have failed immunotherapy, can they be included in your study? And does it matter which immunotherapy they failed? And if you could just talk about what phase they would enter.
Yes. So right now, we are welcoming patients who failed immunotherapy if they are belonging to the hepatocellular carcinoma category, because the study is a combination, cabozantinib with durvalumab, and so if they fail atezolizumab and bevacizumab, which is the standard of care now in the frontline setting, they could be enrolled in the study, because one of the things that we're going to look at is whether cabozantinib reverses resistance. However, in the gastric cohort and in the colon cohort, it is still early to accept post-IO population in the study, because it might mess how we're going to interpret the trials. Also, one of the other things is, IO monotherapy is not really the standard of care in earlier setting in gastric. It's not the standard of care at all in colon cancer. And so it should not impact study enrollment at this point, but we could, if there's changes in terms of standard of care as the study goes, we could always change and amend based on what we have in the market.
That's great. Thank you, Dr. Saeed.
Thank you.
We'll move along to our third speaker. Our final program speaker is Dr. Anup Kasi. He is an assistant professor of oncology at the University of Kansas School of Medicine. His clinical interests center around pancreatic cancer, colon cancer, and neuroendocrine tumors. His research interests include pancreatic and colon. He has investigator-initiated trials. He's interested in developmental therapeutics and a translational research approach. Dr. Kasi serves on the National Cancer Institute's Pancreatic Cancer Task Force, and he currently leads the ASCO COVID registry here at KU. Dr. Kasi trained at KU. He's homegrown. We're really pleased that he stayed. Please, Anup, we're anxious to hear your presentation.
Right. Thank you, Dr. Doolittle, for the answer. So can I share my screen? Alrighty. So is everybody able to see see the slides? And can you hear me?
Yes, we can hear you. And if you go to your display settings, you can change your display settings to see your full slide. We're seeing your presentation mode. So just click upon display settings.
Display settings.
Also, we're having a little trouble with the volume. So if we can speak up just a little bit, that would be great.
Is this better?
That's perfect. Thank you.
Okay, perfect. Let me see how to change the display setting here. Mhm. Okay, now do we have the full screen?
And Anup, this is Andy. You want to go up to the upper left where it says display setting, click on that, and then click on the very top. Yep, swap preference.
Oh, I see. Okay.
There you go.
Better. All right. Okay.
Thanks, Dr. Godwin.
Andy. Yeah, thank you. So yes, thank you, Dr. Doolittle, for the opportunity to present, and I'm honored to present our findings, results from the neuroendocrine cohort of the SWOG S1609 trial, which is a phase 2 basket trial for rare tumors using dual anti-CTLA4 and anti-PD-1 checkpoint inhibitors. And as we all are aware, in 2019, the Nobel Prize in Medicine was given to the discovery of these two checkpoint inhibitors, CTLA4 and PD-1. And also last year, ASCO announced that the progress in treating rare tumors as they advance in cancers for 2019. So with that spirit of these two intertwining concepts, I, along with the primary investigators and the rest of the investigators of this trial, the DART study, envisioned this trial as the opportunity to treat these rare tumors with immunotherapies, especially checkpoint inhibitors, which have never been investigated. And of course, we're focusing on the neuroendocrine cohort here. And this trial was open here. It is still open. There are other cohorts that are still open. And we accrued well on this trial, and we're fortunate to share authorship on this paper published in Clinical Cancer Research. So these are my disclosures. So we are aware that rare cancers by themselves, they're unique. Each cancer is still small numbers in terms of incidence, but if you pool all of them as an aggregate, they constitute about a quarter of all cases on an annual basis. And as we see an increased trend in the common cancers, along with age, we also actually see an increase in the trend in the rare tumors for this population as well. In terms of the distribution of the major types of rare tumors, it is obviously a heterogeneous group. And if we focus on the neuroendocrine population, it's a small population of 2%. Now, these are the various tumor types that were included in the DART study for rare tumors. So as I said, this is a basket trial that had more than 37 types of rare tumors and more than 50 cohorts. So the DART study is basically the first NCI-funded rare tumor study to be treated with immunotherapy in a basket study fashion. And the primary objective of the study was to assess the tumor shrinkage measured in terms of the overall response rate using the RECIST 1.1 criteria. And in terms of the treatment strategy, this included a combination of immune checkpoint inhibitors. The dose of IPI is much lower than what is used in melanoma. Here it is 1 milligram per kilogram. given every 6 weeks. So it's different from what Dr. Doolittle uses for his patients. And this is combined with Nivo or nivolumab at a flat dose, 240 milligrams every 2 weeks, and is given continuously until progressive disease or toxicity or withdrawal. So just briefly, some background in terms of neuroendocrine neoplasms. These are, heterogeneous grouping in themselves, and they occur throughout the body. While many of them are well differentiated and low-grade tumors with more indolent disease course and biology, about a third of them do tend to be poorly differentiated or high-grade tumors, and most commonly occur in the lung, GI tract, or other unknown primary sites. And they generally have a more aggressive biology and very few treatment options, mainly cytotoxic chemotherapy-based options. Now, these tumors are divided based on their primary site of origin, that is, pancreatic versus small bowel versus lung, etc. That's one way to classify them. And then we also look at the other classification is based on the proliferation rate, where we look at the mitotic index or the Ki-67 and grade them as low grade versus intermediate grade versus high grade tumors. I briefly wanted to review this study. This is a small retrospective study that was our experience at the University of Kansas Cancer Center. This was published back in 2014, where we looked at our high-grade tumors at KU, which were outside the lung. And what we found was that if these were localized disease, then their survival, median survival was up to 36 months. But if they had extensive disease, widespread disease, or stage 4 cancers, then their survival was poor at 5 months, and that was statistically significant. Here, we also found that the GI and GU tract tumors were the most common type of high-grade neuroendocrine neoplasms. And when we looked at the survival based on the primary site of origin, we found that the GI tumors did poorly, and so did cancers of unknown primary. When we compare this to GU and GYN and head and neck tumors, they did better in terms of survival. So we know we have that background, and in terms of utility of or efficacy of anti-PD-1 treatments as single agent monotherapy in high-grade neuroendocrine carcinomas, that has been studied previously in a small study where we saw a response rate of 5% at best. So not great, not impressive. Now, this study in the DART trial, there were 32 patients in the neuroendocrine cohort. Of note, this cohort did not include pancreatic neuroendocrine tumors. Given their unique biology, they've been included as a separate cohort, and the accrual has been completed, but we're waiting for the data to mature. So out of these 32 patients, 56% of them had high-grade carcinoma. And in terms of the primary site of origin, half of them were GI origin, and about 1 in 5, or 1/5 rather, were lung origin. And in terms of their prior treatments were cytotoxic chemotherapy-based treatments. These patients were treated and heavily pretreated, with a median number of prior lines of treatment being 2. So this is the baseline demographics from the study. As we can see, the median age was 60.5. Various primary site of tumor origin. We have GI, GU, GYN as well, and unknown primaries. And we already went over the big breakdown in terms of the grading and prior lines of treatment. Majority were white, 78% versus 20%, 19% black, and 3% Asian. When we look at the efficacy in terms of response, objective response rate stratified by the primary site of origin, we didn't really see a difference whether it was a lung primary versus GI primary or GYN primary or unknown primaries. So that was no difference in the objective response rate based on primary site of origin. However, when we looked at the response rate based on tumor grade, we found that the high-grade neuroendocrine neoplasms had a much better objective response rate, as you can see in this waterfall plot with the bars in the pink. And these were mainly high-grade, poorly differentiated neuroendocrine carcinomas, but there were some high-grade tumors that did not respond. If you look at the low and intermediate grade tumors, they didn't really shrink or respond. So when we look at, one of the salient features of immunotherapy is the durability of response. And I'm sure Dr. Doolittle can attest to this. And it's important to note that especially in the high-grade neuroendocrine neoplasms, that these responses have been ongoing, and some patients have gone beyond 1 year with a controlled disease. And it's really rewarding in the clinic. I have a couple of these patients to see these patients not be on chemotherapy and be on immunotherapy and continue to respond and, or rather have a durable response for prolonged periods. So again, kind of refreshing on the efficacy endpoint, the objective response rate for the high-grade neuroendocrine carcinoma cohort was 44%, independent of the primary site, whereas the low or intermediate grade neuroendocrine tumors, the response rate was 0%. They did not respond at all. And if you look at breakdown by the primary site, pulmonary high-grade neuroendocrine carcinomas, the response rate was better, 66%, whereas the GI patients had a response rate of 25%, and the other high-grade neuroendocrine carcinomas had 40% response rate. Now, this did translate in terms of survival benefit. If we look at the clinical benefit rate of more than 6 months was seen in 44% of high-grade tumors, and the 6-month PFS was about 31%, and with a median overall survival of 11 plus months. We have to keep in mind that this is still a small study and needs further follow-up. So in terms of the toxicity, it is a fairly well-tolerated combination regimen. We did see high-grade immune-mediated hepatotoxicity in terms of ALT and AST elevation. There was also about 6% incidence of colitis, but no incidence of high-grade pneumonitis on the study, and there were no deaths on the study, no grade 5 toxicities. In terms of the limitations, there was no central pathology review, so we had to bank on the local sites for adjudication of the site of origin of the tumor, as well as the grading, the mitotic rate and the Ki67 information. And in terms of the high grade versus low grade, intermediate grade analysis, this was not a pre-specified analysis. There is another formal high grade neuroendocrine carcinoma cohort that is ongoing in the S1609 trial. And so the data that has been accrued and that cohort is closed, but the data has to mature. So again, when we stratify based on lung versus non-lung primary side, we saw that for the lung primary side, the response rate was 66% versus for the non-lung cohort was 40%. So again, we have to keep in mind this is a 32-patient study. It's a single-arm, non-randomized study. So we do need, randomized trial and a larger trial to confirm these findings. But nevertheless, I think these response rates are, promising in terms of ability to get 40 to 60% response rate in a heavily pretreated patients of neuroendocrine, high-grade neuroendocrine tumors is something that we have not seen in the clinic. Now, in terms of the DART trial, it's still ongoing. There are several cohorts that have closed, but these are the open cohorts for rare tumors. So if anybody has patients that belong to any of these diagnoses, certainly do consider enrolling on this trial. So in summary, the DART study is the first NCI-funded study for rare tumors, testing immunotherapy as a basket study with its unique design and scale. And there were more than 37 rare tumor types treated with a combination of AP and NIVO. And as we went over the results, they are promising, and the benefit is mainly in the high-grade carcinomas, independent of primary site, 44% response rate. And also of note, the high-grade neuroendocrine carcinoma, the cohort accrued in within 2 months, 8 weeks, but the data is maturing, so we're still waiting for the efficacy data on that high-grade cohort. And in the broad sense, I just wanted to highlight that though these tumors are rare, historically it's been a challenge to conduct clinical trials for rare tumors. But this study shows that it is feasible. This study was open in 800 plus sites throughout the country. And about 2/3 of these patients were actually enrolled and treated in the community setting. More than 700 patients were enrolled in all these different cohorts in 2.5 years. And in terms of our neuroendocrine cohort that we looked at, those 32 patients were enrolled in 3 months, which is pretty fast. And the high-grade neuroendocrine cohort, that was enrolled in 2 months. So it is possible to conduct clinical trials in rare tumors. So with that, I'll stop. But before actually I let you go, I just wanted to highlight my investigator-initiated trial in pancreatic cancer called the NIDA-PANC trial. This is a phase 2 study of using a PARP inhibitor called niraparib for unresectable pancreatic cancers or metastatic pancreatic cancer with a DNA repair defect. And if patients have progressed on first-line treatment or even beyond, first-line and beyond, or let's say they started their first-line treatment, but then due to toxicities, they're not able to tolerate that any further, then those patients are eligible. So the pre-screening for this trial is the good strategy here. While patients are on their first-line treatment for unresectable cancers or metastatic pancreatic cancers, we can easily pre-screen these patients, and screening is being done for the biomarker testing is being carried out at Dr. Baldwin's lab. So these, there are a panel of close to 30 genes that we will be testing for mutations, and if they harbor a defect in these genes, then they qualify for this clinical trial. So if you're treating patients with pancreatic cancers, then please keep this study in mind. So with that, I'll stop and take any questions. Again, thank you for the opportunity to present, and also wanted to thank our patients, their caregivers. Really, without their willingness to participate in clinical trials, we would not have these results to share with you today. And right now I'm using immunotherapy for our patients with high-grade neuroendocrine tumor based on this trial, even though it's not yet FDA approved. So thank you for all the contributions.
Thanks, Dr. Kasi. Really appreciate it. That was excellent. And that was actually one of my questions. Since it is so difficult to conduct these trials, are we willing to move ahead in a standard of care manner, given these kinds of numbers and what it will take to get a truly prospective randomized group studied properly? Would this be enough for you to go to an insurance company and argue for payment?
Yes, I have been ordering combination immunotherapies for high-grade neuroendocrine tumors in my clinic, and at times we do get peer-to-peer requests from insurance companies, but then I support that with the publication, the results from this trial, and I've had success getting that approved.
Right.
Just to follow that question, if you say small cell type or large cell type, so many times you may win, you may get to the support.
Exactly. That's a good point, Dr. San. Yeah. That does make a difference.
Great. Thank you. Are there any other questions for Dr. Kasi? I know we're running a little bit over today. Anything else?
We do not have any other questions, Dr. Doolittle.
That's great. If we missed your question, please reach out to us. You can contact us through the Masonic Cancer Alliance website, so www.masoniccanceralliance.org. Would really like to thank our presenters today for sharing their time and expertise. A special thanks to those of you that participated. We know your schedules are really quite busy, so we very much appreciate that and that you were with us today. Stay safe, stay well. good weekend. This is the first of a series that we'll be moving forward with that highlight particular research projects that are ongoing, projects that many of our sites have contributed patients to. So thank you and good weekend.